Now looking at the calcaneocuboid joint, this joint is not as flexible as the talonavicular joint. So we are on the lateral aspect of the foot, and again the calcaneocuboid joint is going to be obviously between the cuboid and the calcaneus. The cuboid articular surface with the calcaneus creates almost a wedge-like shape between the two that helps support the lateral column of the foot. This joint is then supported by a few ligaments. Let's look at those real quick, actually, before we move on. Alright, so again, here's our calcaneocuboid joint. It's a little difficult to see here, but they do interlock with each other quite well, and then these ligaments help support. So again, we have the bifurcate ligament that helps, and then laterally we're going to have this dorsal calcaneocuboid. On the plantar aspect of the foot, we have the long plantar ligament, and then there's also a short plantar ligament. Now, this long plantar ligament pretty much is like a baby version of the plantar aponeurosis, I guess you could say, but it's going to be along the lateral aspect of the foot, so it's going to aid the lateral longitudinal arch more so than like how the plantar aponeurosis helped to support our medial longitudinal arch. Alright, let's go ahead and go back real quick. Alright, so pretty much the movements of the mid-tarsal joint, so of the talonavicular and calcaneocuboid joint, allow for motions of pronation and supination to occur, which your orthotic teachers will go into more detail about. Long story short, pronation and supination are motions and are movements. They are triplanar movements that they'll just go into more detail about. But it's the position that the foot's in. There's a difference between a high arch and supination. And if someone says a pronated foot, that's not correct. They are going through pronation. Pronation and supination are movements, whereas a flat foot or a pes planus is a state or a diagnosis. It is static. So think of pronation and supination as dynamic motions rather than as static fixed position. Anyway, your teachers will go more into those two motions and break those down in a lot more detail, but know that the mid-tarsal joint is a triplanar joint. It's heavily reliant on the motion of the subtalar joint pushing into both of those, and yeah, that's pretty much it. It's where we can have some breakdown occur in this transverse tarsal joint if the foot is not operating properly at the next further joints down. So either at our metatarsal phalangeal joints or at other joints, we can have some breakdown in this midfoot region if we are getting improper stresses dispersed in other areas of the foot. Alright, so one last thing, the talonavicular axis and the calcaneocuboid axis, sorry this picture's a little blurry, but these two, when the calcaneus and subtalar joint is in neutral, then the axes of these two should be parallel. So you can see if we have an inverted calcaneus, so our calcaneus, the distal end is more towards the midline of the body, then we can see that these two axes are not going to be parallel to each other. There's a few other images floating around sort of like this on online, and it also shows an everted calcaneus ever so slightly, and it shows these axes almost parallel. And if you remember, we have limited calcaneal eversion or limited eversion in our subtalar joint because we have that bony block from the lateral malleolus. So that's why some of the pictures when it says everted calcaneus, these two axes look like they're parallel because remember we only have about 5 degrees of motion and eversion in the foot. So that would make these two axes not exactly parallel, but the images that are out there usually look parallel. So just keep that in mind when you are looking at why some of the pictures show up the way that they do. Alright, we just talked about the mid-tarsal joints, and so now we are going to discuss the distal intertarsal joints. So just like in your wrist or in your hand, how you have all those carpal joints, we also have intertarsal joints. These are made up of the cuneo-navicular, cuboideo-navicular, anterior cuneiform, and cuneo-cuboid joint. Wow, these are real words, I promise. I'm not going to go into detail about all of these, but the overall function of these joints is to create and assist the transverse tarsal arch. Let's actually go look at this right now. So, looking at our tarsal bones, again a little bit closer, all of our cuneiforms, we're going to have those in contact with our navicular. So we have one joint right in here, our cuboid navicular, which is going to be in between here, our intercuneiforms between the cuneiforms, and our cuneo-cuboid, which is going to be in between here, right in here. Okay, so all of these joint spaces are going to have thin capsules and thin articular cartilages that allow for the movement between each of the joints. Typically, though, these distal intertarsal joints aid in pronation and supination along the midfoot, but are typically small in nature and not really discussed as in depth as the other joints. So, looking at the ligaments, again, we have the bifurcate ligament, the intercuneiform ligaments, and then there's a few that are not shown in here, but they're just tiny little ones that help connect. Most importantly, we will have our extensor digitorum that's going to come over and help keep a lot of these tarsal bones in place and running together. Okay. One thing. Oh, right. Okay, so I didn't mention it earlier, but the intermediate cuneiform right here is the keystone of the transverse arch, according to Newman on page 600. All right, so remember we had the cuboid as the keystone of our lateral longitudinal arch, the head of the talus as the keystone of our medial longitudinal arch, and now we have the intermediate cuneiform as the keystone of the lateral longitudinal arch. Alright, I am tired about talking about joints, so let's get the rest of these over and done with. Tarsometatarsal joints are going to be, again, between the tarsal bones and the metatarsals. They are right here. And again, the three cuneiforms are going to be articulating with the first three metatarsals, and then the cuboid will be with the base of the fourth and the fifth. We're going to have our ligaments supporting dorsally and plantarly, the tarsometatarsal ligaments, pretty straightforward. And then we have some that go to multiple ones. So, like we have the lateral cuneiform that has two, so on and so forth. So each of these, and we have little intermediate ones that go between them. But anyway, you will notice that there is not a large one here between the first and second metatarsal, and that allows for more motion of our first metatarsal. Majority of the motion that comes in the tarsometatarsal joint is going to be in our first, our fourth, and our fifth. So our second and our third, you see they have the most tendon, or the most ligaments. So they're going to be very stable in comparison to our first, fourth, and fifth. All right. One pathology that you will come in contact with in our profession is something called Charcot foot. So Charcot foot happens when there is a breakdown of the osseous structures in the foot due typically to diabetic complications. And what happens is, rather than the foot, what we call breaking right here for the windlass mechanism for push-off, the arch of the foot is no longer in a supportive position and instead has begun to drop, and the foot is now breaking here. So a lot of times we will see patients with Charcot foot deformity have a breaking of the foot here. A lot of times patients that are overweight, the weight has damaged their arch so much and their plantar fascia so much that rather than pushing off from here, they're going to push off from this point. Or we could have someone that has a painful metacarpal phalangeal joint, a painful MTP joint that allows them not to be able to push off from here, so they're breaking right here. Ms. Hill does a very good impression of how the midfoot breaks, and it's really kind of creepy looking, but she does it well. So ask her about it. She'll probably show you. Oh my goodness. Okay, cool. All right, sorry, that was the other foot. All right, so that is our tarsometatarsal joint. If we come down here and look at our MTP joint, our metatarsal phalangeal, this one's pretty important, especially on our first ray, because this is a site of pain for a lot of people because of just different injuries. So turf toe, there's a lot of different pathologies that go into this joint that your orthotics teachers will go into more detail on. But again, this one's going to be the most flexible. These will be more rigid, and then the outsides are going to be a little bit more flexible. So yeah, that's that. They also have collateral ligaments on either side. Additionally, with the phalanges, they are all going to have collateral ligaments as well. Let's go ahead and look at those ligaments really quickly. All right. Yeah, interphalangeal. That's good. Let's see where those collateral ligaments. Loading.
It's 1 o'clock.
Oh, my computer told me it was 1 o'clock. Wonderful. Alright, so again, here's our collateral ligaments on our proximal and distal portions of the foot. Alright, so nothing much else. Kind of like in the hand, you'll also have some of the volar plates along these that help keep your them from overextension. So yeah, that's that. That's all I have to say about those. Alright, so that is the foot and ankle from the bones, the joints, the ligaments, arches, and now we finally have made it to muscles. So let's get going on that.